Dr. Neha Shree, and she will be presenting on bilateral proptosis in adult. Over to you, Dr. Neha.
Good morning all. I will be presenting bilateral proptosis in adult, a diagnostic dilemma. So this is a story about a 60-year-old male who presented with the swelling in both eyes for last 1 month, which was gradually progressive. Just a minute. Yeah.
Is the slides okay?
Yeah, ma'am. Now
Okay.
it's okay.
You need help, let us know.
It's okay. And it was associated with the pain, and there was a history of asthma for last 10 years. He was also a chronic smoker. So on examination, there was both eye proptosis, lid edema was present, periorbital edema was present, conjunctival chemosis, congestion, and there was 4 mm of lag ophthalmos. Extraocular movement was restricted. I will be showing in the next photograph. And there was also a palpable firm mass in superior-temporal orbit. There was no palpable lymph node, and bilateral fundus was normal. Vision in the right eye was 2/60, in the left eye it was 3/60. People were normal, and both eye has a senile cataract. So this is a photo of extraocular movement restriction. We can see there is a severe degree of extraocular movement restriction was present. And on CT, we advised patient CT scan because we had palpable mass, firm palpable mass. So CT showed proptosis, thickening of lateral rectus with few hypodense area in between the swelling, and it was abutting the optic nerve compression, and it was pushing it medially. And the isodense mass was also seen, we can see in the coronal section, isodense mass was also seen in superior temporal orbit with preseptal soft tissue edema. So what can be the diagnosis? These things came into our mind. It can be non-specific orbital inflammatory disease. It can be thyroid ophthalmopathy involving medial rectus muscle. It can be lymphoproliferative disorder. So what next? So since we had a mass, so in the superior temporal orbit involving, and along with the mass involving the medial rectus, we went ahead with the incision biopsy. We showed, GMSA showed the presence of lymphoid cells, and histopath showed rich reactive lymphoid hyperplasia, but no definite malignant cells were noted. And ISC were suggestive of reactive lymphoid hyperplasia. But when we reviewed the HP slide, I'm sorry for the interruption.
So just in the meanwhile, Dr. Neha,
Yes,
in the differential
sorry.
diagnosis,
Yeah,
thyroid ophthalmopathy that you have put it, so if we have a lacrimal gland enlargement, probably we would take it out of the provisional diagnosis.
Actually, we kept in the differential diagnosis because there are reported with the adenitis associated with the thyroid ophthalmopathy.
How many case reports?
3 or 4 case report we have seen that there are, we have not seen any, but yeah, the case reports are available with patient presenting with thyroid ophthalmopathy associated with adenitis.
In thyroid eye disease?
Yeah, in thyroid eye disease.
Okay.
So one of the differential was kept in mind. कोई नहीं इसे लाते पेंडर.
She can read out.
Yeah, you can read out
Yes,
no
ma'am.
pictures except for the
Is it
Yeah, photos are there, ma'am.
Photos
Yes, yes.
Okay, her
I just-
differential diagnosis, one is a lymphoproliferative, one is a thyroid, and the third one, what she mentioned, some tumor, right? Okay. By looking to the CT or MRI, how do you know it's a lymphoproliferative, or how do you know it's a lymphoma? Any one of you, residents? See, if it's a lymphoma, it will mold around the globe. You'll not see any indentation on the globe. So when you see a MR, you'll know that yes, this is a lymphoma. It just molds so beautifully, and you see the globe shape is maintained so well. So this is a very nice way to diagnose whether this is a lymphoma or not. If you see any globe indentation, usually it is not a lymphoma. Lymphoma never indents the globe. It will just keep on molding around the shape of the globe. So the globe distortion is not seen, which I couldn't make out well in her CT because the cut sections were not very appropriate to evaluate. But when you go through all the cut section, you'll never see any denting.
So I think, Dr. Neha, it was more of a lacrimal gland involvement and the lateral rectus involvement,
Yes.
right? Yeah.
Yeah.
Which, of course, in a lymphoid, lymphoproliferative lesion, it can
Yes, it
separately
can.
happen. Yeah.
So, CT SORE, I've already discussed the CT scan. So, these things were our differential. And we went ahead with the incision biopsy, enzymes are stored, and lymphoid cells. IC was suggestive of reactive lymphoid hyperplasia. So when we went ahead to review the slides, we saw the lacrimal gland tissue with the mixed inflammatory cells, with numerous eosinophil, lymphocyte, plasma cells, and lot of fibrosis around the duct, and which with a few reactive lymphoid follicles. The fibrosis, this lot of fibrosis was not going to favor of the lymphoproliferative disorder. So at this point, our HPE diagnosis of angiolymphoid hyperplasia was made. And one of the differences, because we saw a lot of eosinophilia also, so Churg-Strauss syndrome was also one of the differential. So we went ahead with the CT chest, which showed multiple lymphadenopathy. P ANCA was negative, C ANCA was negative, serum AC level was within normal limit, thyroid function test was within normal limit, thyroid antibody test was also within normal limit, but absolute eosinophil was raised. So coming to a case summary, I'll just briefly discuss. 70-year-old male with asthma, complaining of diminished vision in both eye and proptosis. CT shows enlarged lateral rectus muscle with the superior temporal palpable mass in the both eye. CT chest has multiple hilar lymphadenopathy. HP and ISC suggestive of angiolymphoid hyperplasia with eosinophilia, with the blood test showing raised absolute eosinophil count. So, in all this, our clinical pathological diagnosis of both eye orbital angiolymphoid hyperplasia with eosinophilia was made. But when we reviewed the literature, we came across a similar entity called Kimura disease. I'll discuss later why Kimura disease. So in the further follow-up, by then patient developed exposure keratopathy despite doing the temporary tarsography, and on scraping he saw fungal keratitis. So we started the patient on intracameral vozole also, and along with the intracameral voriconazole, patient was also started on oral and topical antifungal with the topical antibiotic and frequent lubricants. So coming to keeping the diagnosis in mind, we started the patient on injection IVMP 500 milligram, and oral and topical antifungal were continued, topical antibiotic was continued, and topical antifungal was continued, and frequent lubricant and IVMP was followed by the oral steroid. So in the further follow-up, patient was doing fine, signs and symptoms were better, but again after 10th day on the discharge, patient developed reoccurrence of signs and symptoms. We can see there is an increased proptosis, increased chemosis, congestion, but there was a persistent left eye fungal keratitis and exposure keratopathy. So we again went ahead with the second pulse of the steroid, and the rest of the medication were continued. So in frequent follow-up, patient was doing fine after the steroid, and follow-up after 2 months the chemosis, proptosis were resolved. There was a left eye corneal healed ulcer, and the scar was present. So I'll briefly touch upon both the entity. The angiolymphoid hyperplasia appears to be a benign neoplastic disorder of the vascular endothelium with secondary inflammatory response. Mainly affects the middle-aged women and typically occurs in subcutaneous tissue of the head and neck, with the orbit being a rare site. Proptosis, swelling, dystopia, and mitosis, lacrimal gland enlargement are most common clinical feature. Loss of vision is due to severe proptosis and optic nerve compression. And Kimura disease, which I already talked earlier, is an entity which shares common clinical and histological feature with the angiolymphoid hyperplasia. The only differentiating point is that lymphadenopathy, peripheral blood eosinophilia, and bronchial asthma are the feature of Kimura disease, not related to not related to the angiolymphoid hyperplasia, which was present in our case. And also, both the diseases are basically differentiated based on the HP report. Kimura disease has lot of abundant fibrosis, and which is not present in the angiolymphoid hyperplasia. And also, nuclear atypia is present in angiolymphoid hyperplasia, but not in Kimura disease. So, our diagnosis confirms that it's a Kimura disease. So treatment of the Kimura disease and angiolymphoid hyperplasia, for both the cases, high dose oral steroid is given, and reoccurrence is common in diseases. Oral propranolol is a proposed adjuvant therapy, and surgery is limited to debulking due to a diffuse nature of the tumor. And immunosuppressants are indicated for the recurrent or the refractive cases unresponsive to steroid. So my take-home message is complete systemic evaluation is must. Clinicopathological correlation is important for the diagnosis in such rare cases. Pulse IVMP can be considered even in case of fungal keratitis to decrease the systemic inflammation. And timely diagnosis and management with pulse IVMP can prevent the vision loss due to exposure keratopathy and optic nerve compression. Thank you.
Excellent presentation, Dr. Neha. One question to you. Did you rule out IgG4 disease in this case?
Yes, ma'am. The histopathology doesn't show any sign of IgG4 disease, and in the IC also there was no
You
features
did.
of IgG.
Yeah, so you ruled out IHC IgG4
Yes, ma'am.
and serum IgG4.
Serum,
also.
yes, yes,
Perfect.
yes.
Yeah, thank you.
Thank you.
Nothing much there. All immunohistochemistry has been done, right?
Yeah, the complete panel was done.
Nice presentation. Like, it's rare to see so much of, eosinophilic lesion in adult.
Yes, ma'am.
So it's when we think about a childhood bilateral proptosis and an adult bilateral proptosis, the differential diagnoses are always different. But it is really rare, and you have very nicely shown adult bilateral eosinophilia.
Thank you.
Proptosis.
Thank you.
Nice presentation, well documented.